This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.
Hello, my name is Dr. Robert Page and welcome to Doc Talk. Doc Talk is a podcast that is produced by the Knoxville Academy of Medicine and features its physician members giving information to patients that are helpful in terms of making their healthcare decisions. And I feel fortunate to have with me today here Dr. Ryan Schmoker. Dr. Schmoker is a surgical oncologist with University Surgical Oncologist at the University of Tennessee. And he is here with us today to talk about pancreatic cancer. Welcome.
Thank you. Thanks for having me.
I understand you're fairly novel to the Knoxville area. You've been here for about a year and working over at UT. Now, pancreatic cancer, it's very interesting to me because I find anecdotally that we seem to hear a lot about it in the media because there are a lot of people who've had pancreatic cancer. But just from a background perspective, give us an idea about what sort of patients are susceptible to pancreatic cancer, what sort of risk factors exist, and what sort of patients should be screened for this, or what sort of symptoms that they would have that you might want to see somebody for pancreatic cancer.
Sure. So pancreatic cancer is one of those cancers that the vast majority of people don't have strong risk factors for. They tend to be patients who, for some reason, either bad luck or some percentage of patients have a genetic susceptibility, but overall the vast majority of patients really have no risk factors. The risk factors that we know of are people that are smokers. That is actually the highest risk factor for pancreatic cancer, but things like recurrent chronic pancreatitis episodes, people who are overweight, and then people who have diabetes are also at increased risks. About 10% of patients have some inherited susceptibility, with the most common being the BRCA1 and 2 mutations. So,
which we see more commonly in the breast cancers.
Correct,
yeah.
correct. But they're also at risk of ovarian cancer and actually pancreatic cancer too.
So, so the risk factors not really a strong part of it. What about your family? If you have a family history of it, would you be more likely to? Would that be something?
Yeah, absolutely. That is actually one of our criteria to screen for genetic conditions that can contribute to pancreatic cancer, and even family history with a couple family members who have had it. We start to talk about putting those patients in surveillance.
Gotcha. So for most cancers, when we think about things like skin cancers or breast cancers, there are screening studies that can be done sporadically for this. Pancreatic cancer, what exists to screen patients? What sort of situations would you look for to look for a patient who might have pancreatic cancer? Why would a patient present to you typically?
Yeah, so pancreatic cancer is sort of lags behind a lot of these other cancers you're talking about because we don't have great screening tests. There are patients who are higher risk who we actually put in screening protocols if there is a known mutation that they fall within, or a strong family history where we would screen with CT scans, endoscopic ultrasounds, where there's an ultrasound on the end of an endoscope, things like that. But the vast majority of patients don't meet screening criteria. There is some work going on to look for blood testing that can sort of increase the likelihood that patients have an underlying pancreas cancer, but those are right now not even FDA approved and only indicated for patients who have high risk for having an underlying disease.
So somebody who's got the BRCA1 or maybe recurrent pancreatitis, someone along those lines.
Yeah.
So symptoms kind of vague in this area?
Yeah, in general, they can be a very wide range. The majority of patients have some symptom, though. The most common are things like abdominal pain, unexpected or unintended weight loss. New development of diabetes is actually very common. And then things like jaundice. It was really the most remarkable one, and the one that patients tend to notice first and then sort of gets the whole workup going.
Right. And the unfortunate thing about pancreatic cancer, as you mentioned, is that a lot of times when it's detected, it may be fairly far advanced.
Yeah, so what we know is only about 15 to 20% of patients have localized disease that are ultimately candidates for sort of a curative intent sort of treatment options.
So, and that would be surgical, typically?
Well, so what we know is that pancreas cancer, even if the CT scan says that it's sort of localized, we know that the vast majority of patients have cancer cells floating around, and so surgery is part of it, and it is necessary to achieve a cure, but not sufficient. So all patients with pancreas cancer do need some sort of systemic or chemotherapy as part of their treatment.
So let's say I'm a patient, I've got family history of a pancreatic cancer, or maybe a relative who had the BRCA1 mutation, first degree relative, or I've had chronic recurrent pancreatitis. Should I go into my primary care physician and ask to be screened for these things, or should there be like a primary screening procedure done? Under what circumstances would a patient present to their primary care, and how would they then present to you?
Yeah, so I think that the most common scenario is patients have a known family history of mutation. They sort of talk with their primary care provider, and if there's concern, a lot of times we get patients just sent to us who are quote-unquote high risk for pancreas cancer, and that could be patients where there's a strong family history, somebody in their family has had a pathologic mutation in one of their genes, or there's numerous family members, and we are actually have the capacity to do genetic testing within our clinic and then put patients into surveillance who need that.
Gotcha. So so maybe an ultrasound or a CT scan would be sort of like the primary test that would be done in these situations?
Yeah, it depends a little bit on age and things like that. So for our younger patients who we know have a mutation, we tend to do alternating MRIs and endoscopic ultrasounds just to reduce the radiation, cumulative radiation dose over time. But CT scan is, from a surgical standpoint, is the scan I actually prefer.
Gotcha. So I'm a patient who's got a family history. I've had these studies done. One of the worrisome things about pancreatic cancer, and I think that I mentioned this when we first came in, is I was in medical school a long time ago, and it was not there was not a high survivability to pancreatic cancer. There were very extreme surgical procedures that these patients used to undergo, and not a lot of other therapies that were really helpful in these situations. But the situations have changed over the last 25 years.
They have quite extensively, actually. So even within the last 20 years or so, our survival rates for all comers has doubled.
Wow.
From about 5.5% to 10%, so we still have a long way to go.
Right.
But we are making progress, and the main reason we're making progress is we have better systemic chemotherapy, multi-drugs, and we are much better at surgery as far as making sure that we get negative margins, get all the lymph nodes out, and that, as you said, these are big-time operations. These are about as big of operations as we do in the belly, and we have, over the last 30 years, taken a procedure that had a mortality rate of 20 to 30% and gotten it down to less than 1%.
Wow.
Or 1 to 2%.
So just perioperative mortality, you're talking about patients who come in and actually have issues so extreme during the surgical procedure that they will ultimately undergo their ultimately die during surgery. But that's not so much anymore.
No, it is.
That's
very
amazing
uncommon.
to go from 30% down to 1%.
Yeah, and that was actually one of my mentors in fellowship, was one of the primary drivers of sort of refining not just the surgical technique, but the perioperative care. It is really a team approach. So you have to have the radiologists, the GI people. At UT, we have residents that are around 24 hours a day. So if there's a problem that comes up, we can address it right at that time.
So you bring up an interesting point, because the Knoxville area and sort of the surrounding counties, fairly heavily rural population, a lot of smaller hospitals. This is not typically procedures that are performed at those hospitals. Am I correct about that?
Correct.
And so if I were diagnosed with if I was diagnosed with a mass on my pancreas, or maybe had recurrent pancreatitis, this would be something that would be better approached at a larger hospital such as UT, as opposed to staying local regionally in some of the smaller hospitals.
Yeah, and what we know is that really the diagnosis, the workup, the surgery, the chemotherapy regimens, all of those sort of things have better outcomes for people who do it a lot. And it's just across the board, and part of that is, you get better at operations, you do a lot, you get better at delivering the chemotherapy, you do a lot, but we also have the ability, if if something goes wrong, to intervene quickly and have seen it before.
Gotcha. So as opposed to having a patient now, this is not something that even these smaller hospitals will have the ability to do typically.
I think every once in a while somebody may attempt something like that, but in general, I would say that is uncommon.
So this is a cancer that you don't necessarily want to be approached by someone who is not fairly well versed, who doesn't have the background, who hasn't done multiple surgeries, who doesn't have fellowship training in that sort of area.
Right. Yeah. And what we know is high volume centers for pancreas cancer surgery is like in the 15 cases a year. And to give you a perspective, at UT we do about 75 to 100 or so.
Wow. So that's quite a few procedures. So, and it's interesting because now what's your typical patient like that you see in your practice?
So, I specialize in pancreas cancer, but also other diseases of the pancreas. So I have some young patients that have precancerous lesions that we end up seeing, but the vast majority of my patients are in their 60s or 70s, and developed jaundice or some other symptoms that ultimately led to a workup and then a diagnosis of pancreas cancer.
Gotcha. Now, I'm actually thinking. I'm thinking ahead of myself. I'm thinking we're going to talk about adjuvant therapy in another situation, and so I'm trying to save that for another doc talk. And if you're interested, and if you want to know more about this, follow up with Dr. Schmoker and myself, because we're actually going to have another one of these doc talks where we talk about some of the treatments that are available. Is there something you want to make sure to tell patients who should be vigilant about this? Other than some of the sort of risk factors we talked about, patients who because we know that early detection is very important. Patients who should be a little bit more vigilant about getting these treatments done, or seeing a specialist to have additional studies done.
Yeah. I think certain things to keep an eye out, not just for pancreas cancer, but cancers in general. As you get older, certainly our incidence of a wide range of cancers goes up. But sort of the things I think we mentioned before, if you are in your 60s or 70s and all of a sudden develop diabetes, I think that certainly should be raising the flags up. If you start to notice that you're having abdominal pain that you can't figure out a good cause for, or you start losing weight and haven't been really trying to, I think those are all things that certainly raise our concern for not just pancreas cancer, but a lot of different types of cancer.
And so not only important to be vigilant because we are our own best monitors of what's going on with our systems, but I think it's also important to know, and I think it's not only important for just people themselves to know, but even for your acquaintances, relatives, to know that there is a center here in East Tennessee. So you wouldn't necessarily have to go to a larger center like an MD Anderson or up to New York or to have this sort of therapy done. It's actually done right here in this area, so you wouldn't have to travel very far. You could have family near here, and so I think it's important for them, these patients, to know that you're available in this area and that this is the kind of treatment that they can receive in this area.
Yeah, and certainly those places offer a lot of things we can't offer as far as clinical trials and things like that, but myself, our group is very straightforward. If there is something that we can offer here that we think that would be beneficial for patients, I always will send patients.
So always more advantageous to stay closer to home. But if you can't, certainly these patients would be eligible to go other places after seeing you.
Correct.
So, well, I think it's important that that the people who are watching know how to be able to get in contact with you. You are at the University of Tennessee Medical Center here in Knoxville. Do you have any other clinics that you go to, or are you basically just at the hospital in and of itself?
So I'm just at the hospital downtown as of this point, but we tend to get a lot of patients, as UT has satellite hospitals with oncologists throughout the area. A lot of the patients will see oncologists sort of closer to home, and then when it comes time to surgical planning or other sort of downstream planning, they come to see us downtown.
Is there a website that these patients can visit to maybe get some more information about this kind of stuff that you...
Sure, yeah. So our group that's University Surgical Oncology has a website. Myself, my partners are all on there, and our phone numbers, emails, all that.
Perfect. So we'll have all that information down at the bottom of the screen. That's what I'm looking at. That's where my hand's going right now, bottom of the screen. So anyway, but we'll have that information for the patients so they can get in contact with you if they themselves, a relative or even someone they know has to have, has this problem. It certainly is important to know that this is available in this area. Dr. Schmoker, thank you so much for joining me here today and giving us information about pancreatic cancer. It's not something that we talk about very often, strictly for the reasons that you mentioned, but I think it is important to know that there are therapies and treatments available, and there are people that are present locally that can help us in terms of approaching these terrible diseases. So.
Well, I'm happy to be here. Thank you for the invite.
Thank you. And with that, that concludes this episode of Doc Talk. Doc Talk is a podcast that's produced by the Knoxville Academy of Medicine and features its physician members giving information to patients that are helpful in terms of making their health care decisions. I'm Dr. Rob Page, and thank you so much for joining us.
This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.